In this video, I'm going to explain in detail about the stress sharing and stress shielding fixation devices in orthopedics. So coming to the contents, by the end of this video, you will be able to understand about the introduction, biomechanical principles of fixation devices, stress sharing devices, stress shielding devices, and various examples of stress sharing devices and stress shielding devices. So coming to the introduction, before going to the introduction part, that is your bone healing, I would like to tell in a brief about what is fracture. So fracture in simple terms is a break in continuity of the bone. There are different classifications of fracture that is mainly based on etiology, based on pattern of fracture, and based on displacement, etc. And coming to the fracture healing, the healing can take place either primarily in the presence of a rigid fixation or secondarily in the absence of a rigid fixation. So bone healing or fracture healing are mainly classified into primary bone healing and secondary bone healing. So primary bone healing occurs with direct and intimate contact between the fracture segments or fracture fragments. So the new bone grows directly across the compressed bone ends to unite the fracture. So the primary cortical bone healing is very slow and cannot bridge the fracture gaps. There is no radiographic evidence of bridging callus with this mode of healing. It usually occurs approximately 2 weeks from the time of injury. So primary bone healing, it will be taking more time comparing with the secondary bone healing. So secondary bone healing is the common type of bone healing. So this is the only method of fracture healing with the rigid compression fixation of the fracture. So this type of fracture healing occurs with the compression plates. Rigid fixation requires direct cortical contact and an intact intramedullary vasculature. The healing process depends primarily on the osteoclastic resorption of bone followed by the osteoblastic new bone formation. So the primary healing that is mainly occurring because of the compression plates with the rigid compression fixation by using the compression plates, and it may take more time comparing with the secondary bone healing. So next is your secondary bone healing, denotes mineralization and bony replacement of a cartilage matrix with a characteristic radiographic appearance of callus formation. The greater the motion at the fracture site, the greater will be the quantity of the callus. This external bridging callus adds stability to the fracture site by increasing the bony width. This occurs with casting and external fixation as well as intramedullary rodding of the fracture. So this is the common type of bone healing as I already discussed in the previous slide. Secondary healing is the common type of bone healing and it occurs with the usage of your cast, your external fixators or your intramedullary nail or rods. So this is about the secondary healing and primary healing. So coming to the biomechanical principles of fixation devices, many types of devices are used for the fixation of fractures. The biomechanics of fixation is based on either your stress sharing or stress shielding devices. So before going to the stress sharing or stress shielding devices, I would like to explain in brief about Wall's law. There is one law that is known as Wall's law. That means your stretcher, the function makes your stretcher stronger. So coming to the biomechanics, there are two types. Again, it is classified into stress sharing devices and stress shielding devices. So stress sharing devices is a type of device that permits partial transmission of load across the fracture site. As the name devices sharing. Stress sharing means we will be loading the fracture site in a partial manner. So when a fracture is treated with a stress sharing device, micro motion at the fracture site induces the secondary bone healing with callus formation. So bone healing is secondary means there will be a callus formation, and bone healing is primary means there will not be a callus formation, and the primary bone healing will take more time comparing with the secondary bone healing. So there will be a partial transmission of load as the name denotes, that is a stress sharing. Will be sharing the stress across the fracture site, and there will be a micro motion occurs at the fracture site. Because of that, the secondary bone healing will be occurring with the callus formation. Cast, rods, and intramedullary nails are examples of stress sharing devices. Next is about stress shielding devices. As the name denotes, shielding, that means protecting from the fracture site from the excessive stress. A stress shielding device shields the fracture site from stress by transferring the stress to the devices. The fractured end of the bones are held under compression and there is no motion at the fracture site. In a stress sharing device, there will be micro motion at the fracture site, But in stress shielding devices, there will not be any motion at the fracture site. The motion will be shielded from the fracture site. Stress shielding devices result in primary bone healing without callus formation and are slow to heal. So stress shielding devices result in a primary bone healing, whereas stress sharing devices result in a secondary bone healing. So primary bone healing occurs without callus formation and they are slow to heal, whereas your secondary bone healing occurs with callus formation and they are faster or rapid than rapid to heal comparing to your primary bone healing. So compression plating is an example of this type of treatment, that is your stress shielding devices. So coming to the various examples, so that includes your cast, intramedullary rods and nails, compression plates, buttress plates, pins, wires and screws, compression screws, sliding hip screw and plates, 95-degree condylar compression plates, external fixators. So first is cast. So cast is a stress sharing device. A stress sharing device allows for the callus formation and thus relatively rapid secondary bone healing. The joint above and the joint below the fractures are immobilized in the cast to prevent the rotation and translation of the fracture fragments. So cast is a stress sharing device. So you can see this is a forearm cast for the fractures of your forearms, that is your radial or ulnar fractures. So the joint above and the joint below the fractures are immobilized in the cast to prevent the rotation and translation of the fracture segments. So early weight bearing is allowed if the fracture pattern is stable, as in a transverse midshaft fracture of the tibia. Occasionally, the weight bearing must be delayed until the sufficient callus has been developed to prevent the displacement, as in oblique midshaft fracture of the tibia. So weight bearing depends upon whether the fracture has been stable or whether there is a sufficient callus formation. It depends upon the weight bearing depends upon the stability of your fracture as well as the sufficient callus formation. So this is a sugar tongue splint or cast. So next example is your intramedullary rods and nails. So these are stress sharing devices that allows for callus formation and fairly rapid secondary bone healing. An intramedullary rod or nail provides good fixation and allows the joints above and below the fracture to remain free for early mobilization. These devices are most frequently used in femoral shaft and tibial shaft fractures and occasionally in the humeral shaft fractures. So this is an example for your locking mechanism of the intramedullary rods and nails. So it may either statically locked or dynamically locked. So these are mainly used for your femoral shaft fractures or your tibial shaft fractures as well as your humeral shaft fractures. So there are two types of nailing in intramedullary nailing. So that is your reamed nails and your unreamed nails. The reamed nails have a large transverse diameter, making them very stronger. However, the reaming may disrupt the blood supply in the intramedullary canal, slowing the endosteal bone healing. They may be statically locked by passing two screws transversely through the both cortices of the bone and through the nail or rod, both proximally and distally. This rigid fixation prevents the shortening and rotation at the fracture site, especially if it is comminuted. So in comminuted fractures and all, we'll be using the statically locked type of locking mechanism. So that is your reamed nails. Even statically locked nails allow for some early weight bearing. Once a fracture develops callus, the proximal or distal screw fixations may be removed to dynamize or create a compression at the fracture site to further enhance the bone healing. And weight bearing is allowed to create a compression at the fracture site. Reamed nails are most frequently used in the tibial and femoral shaft fractures. So this is the reamed nails, that is your large reamed nails, and this is the small unreamed nails. So there are two types of nailing, that is your reamed nailing and the unreamed nailings. That is mainly used for your tibial and femoral shaft fractures. Next is about unreamed nails. They are smaller in diameter and therefore tend to have less strength, although they maintain a better endosteal blood supply. Unreamed nails are most often used with the open fractures. They are most used in a statically locked, dynamically locked, or unlocked positions. They are used less frequently than the reamed nails. So unreamed nails are smaller in diameter and they will be having less strength, but they won't disturb your endosteal blood supply, and they will be used for your open fractures. It can be used in a statically locked, dynamically locked, or unlocked positions, and they are less frequently used than your rimmed nails. So this is a statically locked tibial nail to stabilize a mid-diaphyseal fractures. And second, this is your statically locked femoral nail. This is a femoral nail to stabilize a mid-diaphyseal short oblique fractures. And another example is your compression plates. The compression plates are narrow rectangular metal plates with curved surface that fit on the surface of the bone and are attached by the screws in such a way it creates a compression at the fracture sites. So you can see here this is a curved like structure, curved like devices, and these are attached by the different screws in such a way that it creates a compression over fracture sites. So that is why it is known as the name denotes, it is a compression plates. So they allow for anatomical reduction and fixation of the fracture. These plates are stress shielding devices because the area of the fracture under the plate is under diminished load. So the area will not have any micro motions to occur, and they will be protected from the excessive motions or stress occurring at the fracture sites. So hence it is known as stress shielding devices. Compression plates are a stress shielding devices. In time, the cortices of the bone under the plate may be thin because they have been shielded from the stress and have a reduced blood supply. So always remember about the Wall's law. That is, function makes your structure stronger. Here, this affected part is not moving or in a non-weight bearing position. Hence, the bone healing will be occurring slowly. Compression plates are most used frequently in the upper extremity, particularly in the radius and ulnar fracture. So this is your humeral shaft fracture. And primary bone healing occurs because of the rigidity of the fixation, compression at the fracture site, and the anatomical reduction. So because the primary bone healing is a slow process, compression plate fixation requires a longer period of non-weight bearing, that is around 3 months, to prevent the hardware failure. So as I already told, stress shielding devices, the healing will be occurring through a primary pattern, and it requires a larger healing period comparing with your secondary healing. That means it takes more time compared with your secondary bone healing. That is mainly through your stress sharing devices. So before fracture healing, all weight is borne by the hardware, which may not withstand early cyclical loading. Secondary support of the fracture site is usually needed, such as with the help of your cast or splint. So always, like, secondary support is needed over your fracture site if you are using this compression plating and all. So we need to use a further cast or splint in order to protect the area. So, but next example is your buttress plates. So these thin metal plates are used most frequently on the proximal tibia after the tibial plateau fractures. So this is one of the classical devices used in a particular area, that is a particular fracture, that is your tibial plateau fractures. So these are used in conjunction with the lag and wood screws to create an anatomical reduction of the fracture. So buttress plates are a stress sharing devices. So the patient is initially kept from weight bearing. So this is a first diagram, that is a L plate. So L plate on the lateral tibial plateau, and B is here T plate on the medial tibial plateau, and C diagram, that is your lateral tibial head plate. So head plate. So this is all about the buttress plates. Next is about pins, wires, and screws. These are thin metal devices that provides the partial immobilization at the fracture site. It may be either threaded, that is your screws, or non-threaded, that is your K-wires and pins. So pins, wires, and screws are stress sharing devices that allows micro motion at the fracture site, and therefore secondary bone healing takes place. So these devices may be used independently or with another type of fixation such as cast to produce further immobilization. So this is a radial head fracture. So by using your pins, and this is a K-wire fixation. So K-wire is known as Kirchner wire. So that is mainly, so this diagram, they use K-wire for the fixation of your metacarpal fracture. So weight bearing is usually delayed. Pins, K-wires, and screws are frequently removed after bone healing has occurred. These devices are often used in ankle, patella, metacarpal, and olecranon fractures. Next example is here compression screws. Compression screws draws fragments of bone together. The smooth barrel of the screw crosses the fracture site, and the threaded portion extends into the distal or lateral part of the fracture. When the screw is tightened, the fracture segments are drawn together in what is known as the lag effect. So these compression screws are stress sharing devices, and therefore the weight bearing is usually delayed. Next example is sliding hip screw and plates. So this is a special device used for the fixation of fractures at the proximal end of the femur. So a sliding hip screw is a stress sharing device. It is most frequently used with the intertrochanteric fractures of the femur. So this type of screws are mainly used for your proximal fractures at the proximal end of the femur, and in this it is most commonly used in the intertrochanteric fracture of your femur. Because of the communication at the fracture site is more difficult, it is difficult to have the fractures rigidly fixed. This device is used to treat subcapital fractures of the femoral neck also. So next example is 95-degree condylar compression plate. Fixation with the 95-degree condylar compression plate is frequently used for the supracondylar fractures of the distal femur. This is a stress sharing device because it is difficult to fix these fractures rigidly. But when a fracture is rigidly fixed, the 95-degree compression plate is a stress shielding device. So it can act as a stress sharing device as well as stress shielding device. Depends upon how the fracture has been fixed. So if the fracture is been fixed rigidly, means it is acting as a stress sharing device. And if it is not fixed, rigidly fixed, means it acts as a stress sharing device. Or if the fracture is rigidly fixed, means it may act as a stress shielding devices. So next is about the external fixator. So external fixator is otherwise known as your external spline or exoskeleton. So this maintains the fracture alignment and length and allow the patient to be mobile. Pins are placed above and below the fracture site, and they are externally united to stabilize the fractures. So these are stress sharing devices, and the secondary bone healing occurs through the callus formation. External fixation is most often used with an open fracture that are associated with the massive soft tissue injuries. If there is a massive soft injuries and we need to treat that soft tissue injuries also, means this external fixator is a good option, because we can able to treat the soft injury as well as the fracture. So this allows the fracture to be fixed and the soft tissue injury to be accessible for wound checks and treatment. So it can be also helpful for your soft tissue injury checks as well as injury for treatment for your soft tissue injuries. So these proximally and distally placed pins eliminate the need to place the metal at the fracture site, and therefore it do not increases the trauma to the bone in the area of the fracture. So it prevents the injury of the bone direct treatment. So it prevents the direct drilling of the different equipments and all. So it prevents these injuries to the bone for the treatment purposes. The external fixator may be used on any of the long bones of the body. So external fixator devices are mainly used for your long bones fractures, that is your open fractures with more of a soft tissue injuries. So coming to the summary, in order to summarize the various devices, so first one is your plaster cast. So the type of fixation is short or long. Healing occurs through a secondary manner. The rate of bone healing is rapid. Biomechanics, it is a stress sharing device, and early weight bearing is possible. Coming to the intramedullary rod, so it is either reamed or unreamed, and healing occurs in a secondary manner, and rapid healing occurs, and it is also a stress sharing devices, and weight bearing is early. And screws, wires, and pins, healing occurs in a secondary manner, and rapid healing occurs. Stress sharing, it is a stress sharing device, and the weight bearing is delayed. And coming to the external fixator, it is an exoskeletal type of fixation, and the healing occurs in a secondary manner, and healing occurs in a rapid way, and it is also a stress sharing devices, and weight bearing, early weight bearing is possible. And coming to the last but not the least, that is your plate, that is a compression type of fixation, and healing occurs in a primary manner, and the healing is, because the healing is a primary way, the rate of bone healing will be slow, and this is a stress shielding device, and the weight bearing will be delayed because of the primary bone healing and because of the slow rate of bone healing. So the weight bearing will be late. It may take nearly up to 3 months for your weight bearing. So this is all about the stress sharing and stress shielding devices, that is your biomechanics of your fixation devices. Coming to the conclusion, bone healing in fractures that heals with callus formation, that is your secondary bone healing, is relatively fast. Fractures that heals with callus formation, that is your primary bone healing, heals more slowly compared with your secondary bone healing. Thus, the amount of time that protected weight bearing is necessary varies not only with the location of fracture but also with the rate of bone healing. So, the protected weight bearing, the amount of time for your weight bearing depends not only with the location of fracture but also with your rate of bone healing, whether the healing take place in a secondary manner or the healing take place in a primary manner. So thank you for watching this video. Please do subscribe this channel and share this video to your physio friends and community. Thank you.